Good afternoon, everyone. Again, thank you for being here with us. My name is Molly Garrone. I'm a Senior Communications Coordinator for the Choices Project at the Prevention Research Center on Nutrition and Physical Activity at the Harvard T.H. Chan School of Public Health. And as always, it is a pleasure to be facilitating today's coffee chat. The topic for today is engaging community partners to advance nutrition and physical activity equity. As always, I want to acknowledge our funders who make this work possible and also share that our Choices work and events are for research and educational purposes only. The intention of our coffee chat today is to provide information, tools, and resources to inform and educate, and we are not looking to influence any specific legislation. If this is your first time joining a Choices Community of Practice coffee chat, or if you're just new to our community of practice, I'll briefly describe what it is. The Choices Community of Practice includes people whose work focuses on advancing obesity prevention, healthy eating, and active living, and want to learn more about how cost-effectiveness analysis can advance their efforts and address health equity. And it's our goal to support these efforts by providing tools, resources, and training opportunities. Our coffee chats are unique, informal opportunities to gather ideas, innovate together, and get to know each other better. And for today's event, we will listen to a brief presentation from our guest speakers, and then we'll have some time for questions and answers and open up the floor to give folks an opportunity to talk a little bit with our speakers. So today's coffee chat will be focused on the ways in which we can effectively engage community partners and build partnerships to promote health equity and prevent chronic disease. And our goals for the session today are for all of you to learn about some useful approaches to engage and leverage community partners to advance healthy eating and physical activity equity. And also for all of you to have the chance to kind of network with peers and hear from others about opportunities or challenges or resources that folks have to share that can support this type of work. And we are really excited to be joined by several team members from the Lowell Community Health Center in Lowell, Massachusetts. The Lowell Community Health Center is a grant recipient for the Racial and Ethnic Approaches to Community Health, or REACH program. Folks might be familiar with. It's administered by the Centers for Disease Control and Prevention. And we are excited to hear from these folks about the ways in which they've engaged partners in developing community-tailored strategies that can promote nutrition and physical activity and reduce disparities in their city. So it's my pleasure to introduce Jeanmerli Gonzalez, who is the Program Director for REACH LoWELL, a Centers for Disease Control and Prevention funded program at the Lowell Community Health Center. Jeanmerli has been at the Lowell Community Health Center for 4 years and has worked with building partnerships and community engagement during this time. And Jeanmerli is also a trained Spanish medical interpreter and completed her comprehensive outreach certificate as a community health worker at Lowell CHC's Community Health Education Center. So welcome, Jeanmerli. We also have with us Niem Nay-Kret, who is a trilingual bicultural community health worker at the Lowell Community Health Center, where she has been employed for over 15 years. She has worked in many departments, including pediatric and behavioral health, refugee and immigrant health, the teen clinic, prenatal care and OBGYN case management, breast health education, and the chronic disease prevention and education program. Niem is a trained medical interpreter, community health worker, and an active community volunteer, and works to improve the lives and health of people in the community. So welcome, Niem. Great to have you with us. And finally, we're also joined by Annalee Diaz, who is the program coordinator of the REACH LoWELL program at the Lowell Community Health Center. Annalee has her bachelor's in public health with a minor in Spanish. And in this role, she focuses on working with community-based organizations, utilizing a systemic approach to assist Lowell's diverse community. So welcome, Jeanmerli, Niem, and Annalee. We are so thrilled to have you all joining our coffee chat today. So at this time, I'm going to turn it over to our speakers, who will be presenting an overview of their REACH LoWELL work, as well as their approaches for engaging community partners to advance work in their community. So I'm going to turn it over to the REACH LoWELL team.
Awesome. Thank you, Molly. And thank you to the Choices team for inviting us to be here. and present on our program. So we really appreciate the opportunity. With me, as mentioned, we have Niem and Annalee, who will say hello during their speaking parts. But I wanted to come on and say hello as well. And I'll pass it over to actually Annalee to kick us off.
Next slide, please. Hello, everyone. I am Annalee. I am the program coordinator for the REACH LoWELL program in the Lowell Community Health Center. So for this discussion, we will be talking about Lowell, Massachusetts, and a little overview of Lowell CHC. And then we'll do a REACH LoWELL deep dive. We'll talk about the role of a CHW. And we will do culturally responsive approaches, learning from outreach, partnerships, and collaborations. And then we'll talk about some recommendations that we have for you guys. Next slide. So the city of Lowell has always been an immigrant city, and this has become even truer in recent decades. Lowell is now home to families from Africa, Asia, Central, and South America, especially in those areas where human rights are in jeopardy and where the conditions of war and torture and trauma abound. Lowell is home to approximately the second largest Cambodian community in the United States, at approximately 30,000 people, and to a growing number of immigrants and refugees from other countries. Some countries include Cameroon, Liberia, Syria, Kenya, Iraq, and Burma. Over 42% of our population speaks a language other than English at home, and these are important considerations to take into account when designing and implementing services. Next slide. So Lowell Community Health Center. Lowell Community Health Center's mission is to provide caring, quality, and culturally competent health services to the people of Greater Lowell, regardless of their financial status, to reduce health disparities, and to enhance the health of the Greater Lowell community, and to empower each individual to maximize their overall well-being. So the 1 and 2 Lowell residents use the health center, and I think we have about 144 medical visits per year, and our fiscal year budget in 2019 was $47.5 million. We serve a diverse patient population, and 66% identify as racially, ethnically diverse. And we provide medical interpretation in 60 different languages for in-person and telehealth visits. The organization has a commitment to social justice and racial equity in all programs and processes. The organization actually unanimously passed a board resolution in June of 2020 declaring racism a public health crisis. Next slide, please. So a little bit about our patients. This chart is important because Lowell is a gateway city with a long history of welcoming immigrant communities. Our patients are as diverse as the Lowell population. A large number of our patients are below the 100% poverty line, and 45% are best served in a language other than English. We reach roughly 1 out of every 2 Lowell residents through our many programs, in addition to primary care, behavioral health services, and our community health programs provide vital resources to the Lowell community. And you'll hear more about our community programs later in this presentation. Next slide. And I will pass it on to Jeanmerli.
Thank you, Annalee. And so as Molly mentioned, REACH stands for Racial and Ethnic Approaches to Community Health. REACH LoWELL is made possible by the funding from the Centers of Disease Control and Prevention. And Lowell CHC really chose REACH because of the existing strong infrastructure at the health center and at the local community-based organizations that this funding will provide basically an opportunity to guide the organization and our community for initiatives that are and allow us to be the coordinating body of a lot of these initiatives. And you'll see how that aligns with our work in a few slides. Next slide. So REACH has a main goal to eliminate disparities among Southeast Asian and Hispanic Latinx community members as it relates to diabetes. And we do this really through systems level interventions, through culturally tailored community-wide and individual education, and culturally tailored evidence-based health promotion activities. Next slide. And so all of this work cannot be done without our very large team who are talented in many ways that support and continue to support the work at Lowell Community Health Center. We have our principal investigator, who's Sheila Och, our senior director, who's Mercy Anempio, myself, Annalee, who serves as our program coordinator. We have Kitana, who's our marketing and communication specialist. And if you've been on our website, you've seen all of the wonderful work she's done with our health education material. We have Niem Nay-Kret, who's currently on our call with us. Ronnie Mal, who also serves as our community health worker. Stephanie, who also serves as our community health worker. We have Vincent, who also serves as our community health worker. Romilda, and who also serves as our community health worker. And many of our staff members are bilingual, bicultural, and they are a part of our team and represent a lot of the community members we work with today. Next slide. And so, interestingly enough, REACH LoWELL does not work alone. Although we are a program, REACH LoWELL really is a coalition of partners who work together towards the initiative that we have in different ways towards our major goal. And so Lowell Community Health Center serves as the lead agency. We're the administrator of the program, while we have Cambodian Mutual Assistance Association, who is our, a cultural service, social service agency. We actually partner also with the city's Department of Planning and Development. Our Coalition for a Better Acre, which is also an agency that supports primarily our Latin population. Merrimack Valley Food Bank, who services our food pantries. No City Grows, which is the Urban Agriculture Organization, and JSI, which is our program lead later. Slide. And so our goals are accomplished over 4 main strategies. Nutrition, with the strategy focused on food systems, really how people access healthy foods, healthy nutrition standards, how people pick foods, and breastfeeding, really the beginning stages of life and feeding. We also work in physical activity, and with this strategy, we focus on the built environment, how people get to where they need to go to access resources, and how spaces promote physical activity. We also look into community clinical linkages. With this strategy, we focus on social need referrals, the accessibility to the resources we provide, and making self-help resources like diabetes self-management and prevention programs available for our community members, really building capacity within our partner organizations to host this type of programming. And lastly, we work in COVID-19 and flu education, promotion, and vaccination, really with a focus on educating and empowering our trusted messengers, while also increasing vaccine opportunity. And I'll highlight this now because we'll focus on this a little bit later, but when we say trusted messengers, definitely considering our trusted messengers as our partners in a lot of the work that we do. And so we kind of use those words interchangeably, but really, our trusted messengers are our partners with the work that we're doing. Next slide. And so REACH LoWELL is a 3-year project. So the CDC REACH program is actually a 5-year funded project. We came in at year 3, and so we started, and we've only done 3 years worth of work so far. In year 1, we focused on information gathering. We listened to the community on what they wanted to do. Really looked at key data and indicators that showed any disparities, and really focused in on strategizing on that. And so in year 2, we implemented those strategies. We said, hey, let's see what the data says this, people are saying they need this, let's try it out. And then we used the findings and the lessons learned from year 2 to inform this year's implementation. And so we continue to implement in year 3 with using the lessons learned from year 2, but also we're planning for sustainability. And we're looking to see how can we continue on this work beyond REACH LoWELL funding. And we're working on that now as we continue to do the work. And you'll see a little bit later how we lean on our partner strengths to be able to sustain our programming. Next slide. And so for the next few slides, we'll really talk about REACH LoWELL's approach. And I'll pass it over back to Niem, where she'll talk about the role of a community health worker.
Thank you, Jeanmerli. The role of the community health workers, I think it's really come up during the pandemic. The essential frontline community health workers that are trusted messengers that have the bilingual or multilingual communications ability. community health worker are engaged that is with the community in terms of cultural mediator. The community health worker engage community members and help them learn about health resources and information. We work with communities to identify and share appropriate resources to meet their needs. We organize and collaborate with the Diabetes Self-Management Workshop with partnering agency, which Jeanmerli just mentioned, example, the Cambodian Mutual Assistance Association, as well as the Coalition for Better Acres. We lead the diabetes groups and facilitate the health groups. We connect and maintain social network and relationship, which could be give and takes, it's a trust messenger. We communicate with the community, and then at the same time, guiding them or helping them navigate social services agency. Community health workers have the knowledge of outreach in the community with attentions to safety for ourselves, as well as with for our colleagues, our clients, our community members, as well as the community in general. We assist with community assessment survey, share information with community, with our colleagues, as well as partners agency. We do help with plan effective program services and advocacy. And next slide. Okay. Compensating expert. Compensating expert is, having lived that experience, have knowledge that we wouldn't have otherwise. We want to compensate and show appreciation, the knowledge that the community share and that give us insight into the community. It's community driven. We talked earlier about voices from the community, community having the input, their feedback, community driven, and long life commitment. I think they live in the community, it's their life, when we put a program into it, we would like them to have that input as well. Cultural mediator. We work with diverse culture. We're talking about new immigrant and refugee, from Central America, Africa, Southeast Asia. So definitely working with all diverse culture. Healthcare access within organization culture, helping them navigate that culture in the organization. We work to enable clients to participate in the healthcare decision. Example I can give was we talk about one of the COVID vaccine. When we ran out of Moderna, it's like, the elder, would you like to get a Pfizer vaccine, for your bivalent? The client said, let me talk with my elder daughter. Let me talk with my family members. Those are the support network, that they needed. We could, the provider give the vaccine, but when they get home, who are the supporter? Who are the people who help them if they have side effects? So we actually call the daughter, and then, let the person have that dignity, have that decision making, involved in that decision making. And that's how the community health worker work with our elder, our community members. We also, look at the culturally, linguistically appropriate services as well. Advocates for accommodation to address community communication needs, as well as for that self-determination and dignity that I mentioned. Thank you. Next slide. In here in the picture, you can see that we have the Metta Health Center, which was used to be in that the first left picture at 135 Jackson Street. And then the next picture you will see with the monk sitting on the chair there. If you know any of the Southeast Asian background, you would know which Southeast Asian country that is. I'm gonna leave you to guess. You can type in your chat which country that is. And then to the right there, and you will see imagine stocking with, the white color, that interfaith blessing at the Metta Health Center, you can probably tell, what a religion that is. And then we have the monks and other religions leaders did the blessing for the Metta Health Center. And the Metta Health Center, it is the nation first fully integrated West Mid East healthcare facility. The Metta Health Center focus on services, healthcare needs of refugee immigrants of Southeast Asian, Cambodian, Laos, and Vietnam, as well as now with new arrival from Afghanistan, Iraq, Congolese, and other countries as well. Meditations. We do have meditation, acupuncture, services here at the Metta Health Center as well. Thank you. I'm gonna pass it back to, was it Annalee?
Yes, thank you, Niem. So from conducting community outreach, we have learned 3 important things that have made outreach successful for us. So the first being meeting community members where they are. So this increases the visibility and understanding of issues. It empowers community members to have a say over decisions that affect their lives, their towns, cities, and neighborhoods. And this also increases vaccine opportunity. So for example, last weekend was Khmer New Year, and we went to a temple to provide some educational information in Khmer, written and verbally. So we were able to meet members where they are, and as well as break down that language barrier. And the second thing that we utilize is trusted messengers. Trusted messengers are extremely important within the community because it helps to educate and empower the at-risk population. So trusted messengers can be anyone. We utilize religious leaders, barbers, hairstylists, business owners. They are members of the community that have already built a strong relationship with the hard to reach population that we are currently trying to reach. So they provide that that kind of mediation and that communication to the members that are hard to reach. And the last thing that we do is culturally tailored community-wide and individual education. This helps to improve health literacy and reduces health disparities. It increases community members' understanding, enables them to use the information to make informal health decisions. And a really important thing that we use is, again, that language, that interpretation. A lot of us on the team speak Spanish, Khmer, Vietnamese, Arabic, Portuguese. So we definitely try to utilize interpretation, translation, and just to break down that language barrier so that our population understands the things that we are trying to tell them. Next slide. So partners, we try to use partners from different sectors. For example, we have healthcare, nutrition, food emergency distribution, and culturally specific social service agencies. Each of them hold a strength in different aspects of our community, social determinants of health needs. And through collaborations, we can lean on these strengths. So this reduces the duplication of efforts. It encourages, supports, and builds capacity for our partners to do this work in order to reach hard to find populations that they're already connected to. And it provides a highlight of existing educational resources, opportunities at partner locations. We all have the same goal of helping our community and uplifting existing work to accomplish this goal. Next slide. So these are our recommendations to you all. The first one is to prioritize intentional partnerships to maximize reach and strengthen strategies. Lean on community-centered approaches. This builds trust in communities. This includes leveraging long-standing partnerships. Assess community needs and to include community voice in program design. Build capacity with existing programming. Incorporate community health workers and trusted messengers. Include different types of resource providers to address systemic barriers. Next slide. And that is all we have for today. This concludes our presentation. This is our social media. If you are interested in following us, we're literally on everything. So please follow us. We post some good content. Next slide. And this is our contact information if you're interested in connecting with us. And that's all that we have. And now we'll pass it back on for any questions.
Thank you so much, Annalee and Niem and Jeanmerli. That was a wonderful presentation. So thank you very much. Thanks for walking us through all the wonderful work that you're doing from such a culturally responsive perspective. It was great hearing those key learnings from your outreach and so much great insight, particularly those recommendations that you had at the end there. So thank you so much. And I think at this time, I'd like to sort of transition us into a full group discussion. And I'm going to start off by asking our speakers a few questions, and then I'll open up the floor so that folks in the audience can ask their own questions. And so I think I'd really like to sort of tie things together and sort of bridge between what we do at Choices and our research and work to all the great work that the REACH Lowell team is doing. So I'll give a little bit of an introduction to some of our Choices concepts and then kind of turn to the REACH Lowell team with some related questions. First, I just want to say it was very interesting to hear your organization's approach for engaging community partners. And I wanted to return to those recommendations that Annalee was sharing at the end there and connect that back to our Choices work. Our Choices research is focused on evaluating the cost effectiveness of different policies and programs. And to do this, we really focus on three key inputs: reach, effect, and cost. And we spend a lot of effort on understanding how many people a particular program or policy could reach and who those folks might be. And so one of your recommendations that you highlighted there at the end was to prioritize intentional partnerships to maximize reach and strengthen strategies. So I'm just wondering, REACH Lowell team, if you could say a little bit more about that recommendation and how your approach in building intentional partnerships helped to maximize the reach of your strategies, how you did this, and if you measured reach in any way.
Absolutely. So our biggest goal is to eliminate disparities within the Southeast Asian and Latinx population as it relates to diabetes. The way that we have built intentional partnerships was to look for community organizations that were already doing the work within the community that had a great impact on the population that we were looking to do work with. So we look to help these partner organizations to continue to the work that they are already doing, or we help them to establish and implement new plans.
I think something I would add to that would be, so when we looked at our partners, one, Lowell is built very interestingly where we are connected by something called a community health network area, or CHNA, and our CHNA is CHNA 10. And so with that, the coordinating body of this whole connecting body, in other words, it's called Greater Lowell Health Alliance. And so there's already an organization that is working towards bringing community partners together to address the needs that come out of our community health needs assessment every 3 years. So someone's already doing that, right? And so naturally, a lot of our partners are very, very involved in that specific CHNA. They're very engaged. They're working towards addressing these community health needs. And this is something outside of what Annalee and I were talking about, but it really does connect how we were able to engage some of these partners within our coalition. So we've already had some of these longstanding relationships with these partners. And some of the things we did was we're like, okay, we're seeing that there's a disparity in diabetes within this specific population. Who are the groups that are already doing work within these sectors? And so we had these connections. We were able to bring them and say, hey, this is what we want to do. This is how we want to do it. Interestingly enough, if we didn't have someone working in a specific space that we needed their expertise or something, what we did was we connected with them. We networked. We found people that knew people, and we talked about our long-standing trust that we have built within our community. I think something that's also important here is that we need to make sure that this is a long haul. This is not a temporary thing. Our partners can see it if we're not being transparent. Our community members can see it. And so if we're in and we're going into spaces and we're kind of extracting information really fast, our partners sense it and they won't want to collaborate. But we have held our community-centered approaches for a long time, and our partners know that. And so when we're calling them to support some of our initiatives, it becomes easier. The conversation and the integration becomes a little bit easier. I hope that brings things full circle a little bit.
It absolutely does. Thank you, Jeanmerli. I think that's great to hear. And thank you, Annalee, for your response before that. And I think maybe just building off of that a little bit, I'd love to hear if you could expand a bit on how this might relate to your goals of the CDC REACH program to promote greater health equity.
Yeah, so these partners are essentially trusted messengers, and a lot of our partners have been around for many, many years. They have already been able to establish a strong relationship with the community members, and the community members also heavily trust these organizations. This even includes Lowell Community Health Center. Over many years, the health center has worked very hard to establish trust within the community, utilizing community-centered approaches. Um, as we look into systemic level interventions using a coalition model has allowed us to lean on partner strengths to make those changes as we have many of the allies at the table. It takes a lot of strategizing, assessment, and mobilization to be able to promote greater health equity. And because of the large reach we have with our community partners, we are able to do just that. I don't know if Jeanmerli or Niem wants to add anything, but that concludes my answer.
For me, like relationship and networking relationship with each individual agency is always important. The agency might change. Example, the Chinatan, that was when they started in late 89, early 90, that was called Chinatan Community Health Area Networking, and our community health center, education center, which is checked now, is part of part of the entity that do training of community health workers. So I just want to highlight that that we train the people who have lived experience as a community health worker, the people, the gain skill, So when I was talking about compensation for the insight to the community members who get trained, and then they go back into the community, it's like, this is how you navigate to get a lactation consultant services. You go here, I need a primary care. Where do I go? I have a new arrival, and then where do I go? Actually, I just got a phone call before I jump on. There was somebody from Bhutan needing a vaccination in order to get to school, for Tdap, measles, and all that. And I was like, oh, that, see, we can, come here at the Lowell Community Health Center, or working with our local health departments, so that way that person can get back, get into school as soon as possible. So when we're talking about collaboration, networking, trusted partnership, the community, I think it's all of that go with it. As well as that give and takes with the community. The community, they need the services that needed that enable them to live their life, whether it's live, working, active, play, or school. And this one, it was for school.
Wonderful. Thanks, Niem. Thanks for sharing that wonderful example. And thank you, Annalee. I'll ask another question here. In our choices work, we sort of recommend that organizations keep a few things in mind when considering which policies or programs to pursue. And those considerations include acceptability, feasibility, and sustainability. So acceptability kind of gets at whether a particular program or policy aligns with the goals of various key partners involved. So does everybody agree that it's a good idea and are actually interested in moving forward with implementing something? Feasibility refers to how easy it is to put the program or policy into place. Do you have the right resources, the right people, and the right support to put a program or policy into place and make it a reality? And then that sustainability piece refers to the ability to keep a policy or program going and actually in place over a certain amount of time. And it's really about asking, do you have the right funding or the right partners to keep the initiative going? So thinking about all of this, REACH Lowell team, could you speak to how you've engaged with your partners to consider acceptability, feasibility, and sustainability of the REACH program initiatives?
Yes, I can talk a little bit to that. And so I think when we start to think about acceptability, I want to emphasize too, building partnership takes time. It's a lifelong journey, in other words. And so we use, like I said before too, we use data to really outline those disparities. So we're using our medical record data. We're using the data that comes out in the census of the needs that are happening within the community. But what often happens is that people see data and they're like, I'm going to action and I'm going to do what I think is best to address this disparity. And so what we do is we look at the data, we say, hey, there's this disparity, and this is the place where the disparity is. Then we gather our partners. We have those conversations with people that we know are doing the work in these areas. Not all of them, but I think as long as we have some of the key players at the table and the key allies, we're able to do some of the work. And then we're also networking with partners that we're missing. And then after that, one thing we did in year one is we did a lot of assessments. We went out into the community. Sometimes it's very easy to say, okay, I'm gonna put a survey out, I'm gonna wait for a few people to respond and then say, okay, this is what I'm gonna do. So we did some surveys. Specifically within our breastfeeding strategy, we did a survey for providers, people who are actually providing the work, and we also did a community survey. And so we learned that a lot of the needs and priorities aligned between both. And so that's how we were able to action some of the things and find what the community needs as a priority. Within our built environment strategy, something that hasn't happened before within our organization is that the city actually went out into the neighborhoods. They sat out, they did a pop-up tent, and they waited. They waited for people to walk by and say, hey, do you want to put insight on this park that I'm standing right next to? It wasn't something like, oh, I'm going to create a block party or nothing like that. They were dedicated and they were planted within the neighborhood of focus. And they were like, hey, like, we want to know what you want to do to improve this neighborhood so that you can use that park more. And so that's what they did. And then they also leaned on people like Niem and people like our other team members, community health workers, people with lived experience to be at that table, because it wasn't that professional with the tie and the badge that went up to them that asked the question. It was people that say, the same language and said, hey, what do you think? And it became more personable, and that's how we gained insight. And so we made sure that the community want was at the table at all times. And then because our community staff represents our community and the community needs to their own circles and their own personal spaces, they informed a lot of the strategies that we have today. And so back to like the feasibility and sustainability. So the goal of the program is not to have a partner organization come up with a program out of thin air. That's not what we want, right? Because that's not sustainable. But we want the partner to take what they're already doing. Maybe they're having these educational sessions or support groups that are not really support groups, and we have a group of elders coming every week to, I don't know, go to a social service, get help for social services. We want them to take that, what they're doing, and pivot that to address the health disparity that was outlined or the need that was outlined. We don't want them to create a new program with a new director and a new manager and a whole new CHWs. No, we don't want them to do that. We want them to use the services that they're already doing. Some people already have diabetes programming happening, in other words. Some people have support groups already happening. Some people have the people coming together already. Why are we going to create additional groups to kind of flood the stream of things? Why don't we uplift that? And so that's what we did. We worked with the Cambodian Mutual Assistance Association and Coalition for a Better Acre, and these organizations specifically had groups going in different spaces. They had people convening, they had different things happening, and so we leaned on that. We leaned how trusted they were, we leaned how in the spaces that they had, and we, as the funding organization, in other words, became the coordinating body. We became the person who gave them a little bit of administrative support so that they can focus on implementing. Why do they have to focus on the paperwork when we're there to do that? They can focus on the implementing and we can support them. Oh, they need an additional community health workers to run this group. We're here, and created a space in it for our partners to do this work. And so the goal was over 3 years, they were more comfortable with facilitating, become natural, become second nature, and we can kind of let them go and they can continue on the work that they're doing. One thing we also did, I know this is a little long-winded, but it's a heavy question, but one thing that we also did is our funding is not like, so we subcontract these partners, And it's not something like it covers the whole entirety of the program. It's not like a huge amount of money either. It's something supplementary. It's like a thank you, like thank you for your support. And what we do is we invite them to our networking calls. We invite them to places where we hear about leveraging fund opportunities, some additional funding opportunities, and say, hey, partner, apply for this and get the funding, you know, and we're there as a support system so that they can leverage more funding to continue that work on. And we try not to leave them high and dry after the season ends. And so we're making sure we're nurturing that relationship, we're supporting it. And then, you know, it's a mutual thing. It's not something that is kind of extractive out of the partner. It's like, okay, they're getting, you know, our support, we're able to address this system problem and do it effectively together. So that's kind of, yeah, I think that may have answered the question, I think.
Thank you so much, Jeanmerli. I think it was great how you really focused on sharing how you really take what is already being done, how, you know, that makes it so feasible and acceptable, and also that partnerships are mutual. I think that was a really great point. So thank you for sharing that. And thank you, REACH Lowell team. Thank you for your wonderful presentation again and for sharing your responses to our questions about our choices work. So thank you.